All right, Dr. Kende Elisha speaking here, founder of MP Certification Academy. Today we're going to be jumping into endocrine system. Once we're done with this, we're going to move to the next body system according to the schedule. So what is the content that we're going to be going through over today for the most part? We're going to do an overview of the endocrine system just to bring in the concepts. There's a lot of concept on the endocrine system. We're going to see how we can remember all of that. And then we're going to be talking about common endocrine disorders, diagnostic tools, pharmacologic management, clinical pearls for MPs, and then exam prep Q&A, rapid fire review, test taking strategy, and tips for this particular system. So overview of the endocrine system, the gland, the hormones, and the function. What are those? So what are the glands that we're going to be dealing with when it comes to endocrine system? It is the pituitary gland. It is the thyroid gland. It's the parathyroid gland, the adrenal cortex, the adrenal medulla, the pancreas, the ovaries, the testes, the hypothalamus. And then the problem that can potentially go wrong with each of the gland is also here. Okay. So now, this gland right now, what hormones do they secrete? The pituitary gland, ACTH, TSH, GH, LH, FSH, prolactin. It is very, very important to know which gland secrete what. Okay, to get things straight on the exam, it is important to understand which what secretes what. Does it make sense? Now, the thyroid gland secretes T3, T4, and calcitonin. The parathyroid, PTSH, the adrenal cortex, cortisol, aldosterone, adrenal medulla secretes epinephrine or epinephrine. The pancreas will secrete insulin, glucagon. The ovaries and testes secrete estrogen, testosterone. Hypothalamus secretes CRH, TRH, GnRH, and GHRH, and those all are full definition. Maybe next time I will have the full definition somewhere here, but I'm sure most of us have experience with this already. Now, they also have a function as a group. So with the pituitary, generally, what does it do? Regulates other glands. Thyroid, metabolism, calcium balance. Parathyroid will increase serum calcium level. Adrenal cortex will help with stress, blood pressure, sodium, potassium balance. Adrenal medulla will do a fight or flight. And that's where we have, when you have a problem, dysfunction here, that is when we tend to have some issues with high blood pressure. What about pancreas? Glucose regulation. Ovaries and testes will help with reproduction. Hypothalamus is a master regulator. That is pretty much the controller, like the controlling system. It helps us or regulate a lot of things in the body. So what exactly are the common endocrine disorders? When we talk about endocrine system, we are talking about it now as a system. We'll talk about the pieces of it, the part of it in brief. Now we're not going to say, okay, those parts, things can also go wrong with them. What can potentially go wrong with this part? We can potentially have hypothyroidism, aka Hashimoto's disease. We can have hyperthyroidism, aka Graves' disease. We can have diabetes type 1, we can have diabetes type 2, we can have Addison's disease, we can have Cushing's syndrome, we can have pheochromocytoma, we can have, which of course, we just talk about hypertension now, we can have primary hyperparathyroidism, we can have SIADH, diabetes insipidus. And then what tools do we need? We're going to be talking about that. But these diseases, what exactly are the key things or the key features that we must focus on, or that the exam is going to really hold us up to on the exam? That is the clinical feature. A patient comes in with cold intolerance, with constipation, with weight gain. See, now you are now connecting with that on the exam, and then you'll be able to know what to pick. So no strategy without content. Absolutely none. You have to have your content. What are we strategizing without content? So look, hypothyroidism, what exactly is the key symptom? We have fatigue, cold intolerance, constipation, weight gain, bradycardia. Now, every time I talk about something, that something is wrong with something, or something is wrong with the meds, something is wrong with the body system, there's got to be a lab to monitor. That is our role, right? We got to know what labs to monitor. So when we have hypothyroidism, what do we see? We're going to see increased TSH, decreased free T4. What about other notes that we need to pay attention to here, which is supposed to be a key concept, is autoimmune, right? Treat with levothyroxine. So we know it's generally an autoimmune. The treatment is also kind of like thrown in here, but there is a lot more to consider though for treatment. We have to consider the food-drug interaction, the drug-drug interaction, the drug-disease interaction. We also have to consider the population. But in general, what do we do for hypothyroidism? We do levothyroxine. Do we have any questions at this time? Any questions? All right, please let me know by raising your hand or by dropping a question in the chat. We're now going to move on to the next patho. Hyperthyroidism, aka Graves' disease. What do we see? Heat intolerance, anxiety, weight loss. So a patient comes in with heat intolerance. They won't say with heat intolerance. A patient came in complaining of heat intolerance. They appear to be anxious or something, or they have weight loss. You say what you see, and you also go with what patient symptomatology, pull it all together. That is called the subjective and the objective data, and then you come up with a diagnosis. But exam will not like throw hyperthyroidism or any of this patho on your face. They expect you to pick it up based on the symptom that they present, right? Now, what labs are we going to be looking for? In fact, the exam can also present with this lab on examination or upon reviewing the labs. You discover the patient has a decreased TSH, increased free T4 and T3, and they also have TSI. So they expect you to be able to connect this with hyperthyroidism or Graves' disease. And of course, they will not tell you that the patient have hyperthyroidism. They will give you this description of symptoms, and then they will say how you're going to treat it. So let me tell you, if you misdiagnose this patient because you don't know what symptom attached or what diagnosis attached to this symptom, you're going to be picking the wrong drug. But anyway, here we know it's hyperthyroidism, so we're going to be picking methimazole. So exam is not going to straight up tell you what diagnosis is. You have to figure it out. So your diagnosis skills is important, period. So look, diabetes mellitus type 1, polyuria, polydipsia, and weight loss. Labs and imaging, fasting blood sugar, anything that is more than 126 is considered, of course, diabetes. Hemoglobin A1C that is more than 6.5%, and then C-peptide will be on the low side. We know it's generally an autoimmune, and of course, insulin will be required. Type 2 diabetes mellitus is often asymptomatic, unfortunately. You know what I mean? You just think you're going about your normal life, you have all this obesity and all that. Hemoglobin A1C more than 6.5%. Fasting blood glucose is more than 126%. So just the same symptom that we see with the type 1 diabetes. All right. But the type 2 though, is mostly due to lifestyle. And I honestly think genetic also plays a role. So what do we do? We definitely work on giving some metformin for type 2. That is an oral anti-diabetic drug. What about Addison's disease? Fatigue, hypotension, hyperpigmentation. What do we see? Decreased cortisol. We see increased ACH. We see decreased sodium level. We see increased potassium. Got to pay attention to that. Your lab that you're going to see is also a trap for you. They're also going to tell you that a patient comes in with, on reviewing the lab, you saw increased CACH, you see decreased cortisol, you see decreased sodium. They will describe this lab and pair it with your symptomatology. Now, it's an autoimmune. You can treat it with hydrocortisone. So now let's go ahead and take a look at Cushing's syndrome. Central obesity, striae, etruism, hypertension. These are the classic signs of Cushing's syndrome. Increased cortisol, dexamethasone suppression tests can also be done. And of course, we have notes here. Generally, too much steroid is the cause of Cushing's syndrome. All right. What about pheochromocytoma? Episodic hypertension, palpitations, headache, sweating. This is a big deal. Okay, something that must be picked up. Episodic hypertension, palpitations, headache, and sweating. Pheochromocytoma. What labs do we need? Plasma metanephrines. You got to treat with alpha blockers and then surgery. So, what about primary hyperparathyroidism? Stones, bones, groans, moans. These are pretty much the clinical features that we see. Increased calcium, increased PTH. You got to treat with what? Pretty much having the part taken out. So whenever you see ectomy, they have to perform some kind of procedure to remove that part. SIADH, Hyponatremia, low sodium osmolality. Confusion, don't worry, this question is about to come. But when questions come, and then we are more alert and in tune with this stuff, you must have your content ready, because those questions you just find yourself guessing on them. Decreased sodium, decreased serum os, increased urine os. It's very common in patients with lung cancer or SSRI, or very common with lung cancer or SSRIs. Isn't that crazy? Just think about your SIADH. A lot of our patients that are actually geriatrics, they experience SIADH quite a bit. So hyponatremia is definitely one of the classic symptoms or one of the classic side effects that we see with the use of SSRI. Diabetes insipidus, polyuria, polydipsia, and of course dilute urine. When urine is dilute, it only makes sense that sodium will go up. And then urine also will come down, right? Because it's not concentrated. Now you got to treat with desmopressin. Okay. Now, diagnostic tools, TSH, free T3, T4, ACH simulation test, dexamethasone separation test, hemoglobin A1C, fasting blood sugar, OGTT, PTH, calcium phosphate, urine, metaphorenes, MRI, pituitary. They are the things that we do for all of this concept. But if you look at it, I linked this test here already. So this is just a reinforcement. Now, in general, how do we manage these conditions? Levothyroxine, what is it used for? Hypothyroidism. This slide right here, you want to spend time on it if you struggle with form. Methimazole or PTU, hyperthyroidism. Metformin, type 2 diabetes mellitus. Insulin, type 1. You know what I mean? Or type 2. Some type 2 can get that bad that we need insulin as well. But for the most part, we don't do insulin for type 2 though. We do metformin, we do oral medication. Hydrocortisone or fluocortisone. That's Addison's disease. Desmopressin, central DI, bisphosphonates, osteoporosis, SGLT2 inhibitors like empagliflozin, type 2 diabetes mellitus. What about GLP-1 agonists like semaglutide? That's very common now for weight loss. It's used for type 2 diabetes, but people actually focus on the weight loss part that they lose sight of what does it does. But let's be careful of this weight loss stuff. You know what I mean? I'm just saying. That's me. Okay. So now levothyroxine. What are the notes that we must keep in mind? Take it on empty stomach. Monitor TSH level. Methimazole. PT in the first trimester only, not beyond that, because it can be teratogenic. Metformin. You have to watch out for GI side effects. Lactic acidosis, one of the common symptoms or things that we see with metformin. What about insulin? Weight gain, hypoglycemia are the very common effect of insulin. What about hydrocortisone? Monitor for blood pressure and electrolytes. Desmopressin, monitor sodium level. Bisphosphonate, you want to take with water upright for 30 minutes. SGLT2 inhibitors, UTI risk, weight loss. What about GLP-1 agonists? Slows GI emptying, avoid in medullary thyroid cancer. See what I'm saying now? Semaglutide will slow GI emptying. If somebody have a medullary thyroid cancer, they have to avoid it. Now, a lot of people are not educated as to when to or not to take these medications. Now, clinical pearls for all MPs. TSH is most sensitive test for thyroid function. Your thyroid function is off. TSH level is one of the gold standard that we want to obtain to ensure that we nail the right diagnosis. Then always check labs before adjusting thyroid meds. Avoid metformin if the EGFR is less than 30. We don't want to take things further down. Check cortisol every morning. Weight loss with good appetite. You think hyperthyroidism. Pregnant women use PTU in the first trimester, then switch to methimazole. Beta blockers help control adrenergic symptoms in hyperthyroidism. So we're now going to go through some of the exam style questions. The way I have them though, I think I have it as, let's go through it as, it's too late anyway to take out the answers. Let's go through it as a simulation. I think that's the way I had it this way. So meaning what? We're going to go through this question. We're going to tear it apart. We're going to study the question, okay? So this is for learning purposes only. This is not for, oh, give me the answer. I don't care about the answer. I want you to be able to actually understand how to read questions and answers. So let's take a look at the first one. A 34-year-old woman presents with weight loss, palpitations, heat intolerance, TSH is low, T4 is elevated. What is the most appropriate first-line medication? A. Levothyroxine, B. Methimazole, C. Propranolol, D. PTU. So now, let's look at how to read this question. A 34-year-old is a keyword. Woman is a keyword. Weight loss is a major keyword because it's going to also direct where to go or direct us on where to go. Palpitations, heat intolerance, automatically, you have to come up with a diagnosis here. What is your diagnosis? Automatically, okay? It's going to help you out. What is your diagnosis here? Forget about the answer. Drop your answers in the chat. What is your diagnosis for this patient? Let's go back to the content. What do we see here? Heat intolerance, anxiety, weight loss. What is hyperthyroidism? Grave disease. Okay? So now, let me say you pick that out in your mind. This is what I'm saying. Now you pick it up in your mind. Okay? Exam is not saying that it is. You will now have the ability to match it up with the right treatment. That is the way it works. No strategy without content. Absolutely none. Do you get it now? So we know the answer is methimazole. Let's take a look back at the content. It says right here, methimazole is used for hyperthyroidism. The key symptom, it says right here, hyperthyroidism symptoms, heat intolerance, anxiety, weight loss, and tremor. Do we get it? All right. Now let's keep it moving to the next question. You see how hypothyroidism is a trap? So you can't go into that exam thinking, oh, I'm not sure. No, you got to be sure. Your diagnosis is a big deal. And in our confident prescriber group, we actually have a separate class for diagnosis alone for all specialties, FNP, AGMP, PMHMP. You know, diagnosis is something that must be learned. Diagnosis is what will take you to another level. If you can't diagnose, what are we treating? But a lot of students worry a lot about, oh, I want to know my farm. And that's good to know your farm. But if you don't know, if your diagnosis is wrong, most likely your pick is going to be wrong too. Question 2. A 42-year-old keyword. If you know your keyword, throw it in. Old man, right, with type 2 diabetes has an A1C of 8.2%. He is overweight and on metformin. What is the next best step? What is the next best step? Add basal insulin, add SGLT2 inhibitor, switch to sulfonylurea, increase metformin. So we are not here to look for answers. We're here to look for, okay, how am I supposed to think critically on the exam? How am I supposed to see the right answer here? A 45-year-old man with type 2 diabetes has an A1C of 8.2%. He is overweight. I'm like, oh my God, it sounds like really bad. Type 2, A1C more than 6.5. That's okay. He's overweight and he's on metformin already, so this is not even touching him. Okay, so it's time to do something different. It's time to add something else for more efficacy. And that is why we are picking what? SGLT2 inhibitor. Now, this is according to guideline. B, final answer. SGLT2 inhibitors like empagliflozin help with weight and CV risk. That is important for this patient at this time. Because what? We said the patient is having type 2 diabetes. A1C is not going down. On metformin already. We know that something's got to be done fast to get the blood sugar down. B, final answer, right? That is pretty much that. So what is the purse for the endocrine system? Your diagnosis is a big deal. What is your clue for each of these symptoms? When you see on your exam, when you see weight gain, cold intolerance, you're going to be thinking right away what? Hypothyroidism. When you see heat intolerance and anxiety, you're going to be saying hyperthyroidism. Bronze skin hypotension, you're going to be suspecting Addison's disease. Moon face and striae, you're going to be suspecting Cushing's disease. Stones, bones, and groans, you're going to be suspecting hyperparathyroidism. When you see keywords like high urine output, low specific gravity, you're going to be suspecting diabetes insipidus. When you see hypertension plus palpitations plus headache, you're going to be seeing what? You're going to be suspecting pheochromocytoma. All right? Now, let's go ahead and talk about test taking strategy tips. Always match symptoms with labs. Know the drug, when it comes to black box warnings, know when not to give it. When in doubt with thyroid, you want to check TSH first. Reproductive age of a woman, you want to consider pregnancy complications for meds. For fatigue, hyponatremia plus hyponatremia, you better be thinking Addison's or SIADH. For weight gain plus buffalo hump, you better start thinking of Cushing's disease. So now that was a preview. Okay, and you're like, well, I thought we were done. No, we're not. We're just getting started. Let's now go through some of the advanced concepts. We're going to go through endocrine disorders overview, symptoms and labs. A lot of them overlap anyways. What we do for NCLEX is also what we do for advanced. It's just that advanced, your roles will now play a role. That's the difference. But it's still the same body system. Does it make sense? Clinical thinking question, endocrine system, common assessment tools. Now, that is now your advanced role. Does it make sense? Pharmacology of endocrine system, then multiple choice questions, answers, test taking strategies, and so on. Okay, so now we're now going to go over the advanced. Honestly, there's nothing advanced about it. Let's be honest here too. But we're now talking about first line, second line, and all that stuff though. For type 2 diabetes, we already know what it is. We learned it in the basics already. We went through the basics first. So what is the first line? Lifestyle modification plus metformin. Type 1 diabetes, what is the first line? Insulin therapy. Hypothyroidism, levothyroxine. Hyperthyroidism, methimazole or beta blockers. Okay, that is kind of the only thing that is different. The labs we went over. Why though? Why behind the labs is also something that we didn't really go over, but it only makes sense. When something is off, then you go for that lab. So it's just about knowing what is off and dealing with what is off, knowing what the problem is and fixing the problem. Hashimoto's thyroiditis, you want to treat with levothyroxine, right? Graves' disease, methimazole. How will you remember this? It is non-mnemonic necessarily. Mnemonic is extra work. I have mnemonics for all of this. The best way I found out to learn this is repetition, repetition, repetition. Hyperparathyroidism, parathyroidectomy or monitoring plus hydration. Hypoparathyroidism, calcium plus vitamin D supplementation. Vitamin D deficiency, vitamin D3 supplementation. Okay, so these are things that we do for these common conditions. Osteoporosis, bisphosphonate. Okay, the things that we have not seen, I'm going to quickly talk about them. We have not seen osteoporosis. Don't forget DEXA scan, calcium 25 hydroxy, vitamin D, TSH are things, labs that we're going to obtain. Why do we need this lab? To see what our bone density is it low? To rule out any kind of secondary causes. And bisphosphonate plus calcium or vitamin D is the main treatment for osteoporosis. What about metabolic syndrome, lifestyle modification? You want to be able to assess cardiovascular or metabolic risk. What about obesity? Of course, we know that we're getting weight gain, sleep apnea, joints start to hurt and stuff like that. The best first line treatment is still diet and exercise, and of course, behavioral therapy. Controlling our mind and controlling what we put in our mouth. PCOS is a big deal too. When we have irregular menses, etruism, acne, obesity. What labs do we need though? Testosterone LH or FSH ratio, pelvic ultrasound, fasting glucose. We're also going to diagnose PCOS and rule out other causes of androgen excess. That's the focus of this workout, of this process. OCP, lifestyle, metformin are the things that we can potentially use as a first line treatment. And then we have adrenal insufficiency. What are the symptoms of adrenal insufficiency? Fatigue, hypotension, weight loss, hyperpigmentation. What labs do we need to order? AM cortisol, ACTH, electrolytes, sodium, potassium. Why do we need this lab? They'll confirm cortisol deficiency and the type. What is the first line? The first line is hydrocortisone or prednisone, excuse me. Now, Cushing syndrome, moon phase. We saw this earlier when we did the foundation. Central obesity, purple striae, muscle weakness. What lab do we need to order here? 24-hour urine cortisol dexamethasone suppression test. And why do we need this lab? To confirm cortisol excess. What is the first line treatment then? Surgical removal of the tumor. And then we have to taper the steroids if we have them on there. We don't stop steroids abruptly. Pheochromocytoma. What are the symptoms that we see? Paroxysmal hypertension, palpitations, sweating, headache. These are things we see with pheochromocytoma. Plasma, metanephrines, 24-hour urine, catecholamines are things that we need to order to rule out pheochromocytoma. We want to confirm catecholamine or secreting tumor, because other things can also have the symptom. But when we do this test, it's going to help us nail whether it's truly pheochromocytoma or not. So what is the solution to what is the end game? End game is adrenalectomy. They have to surgically remove the tumor. What about hyperaldosteronism? Hypertension, hypokalemia, fatigue are things that we see. Plasma aldosterone, renin activity, electrolytes. You want to assess for primary aldosteronism. Spirulactone or surgery are things that we need to use to treat hyperaldosteronism. Then we have hypogonadism. That is in men. We have menopause in women. We have prolactinoma. We have SIADH, and we have diabetes and insipidus. We're going to quickly go through each of them. With hypogonadism, what do we see? That means somebody have a low libido. They have erectile dysfunction, decreased muscle mass, And of course, total testosterone, LH, FSH are the labs that we're going to draw to rule out this condition. But why do we need it? Of course, we have to confirm because other things also carry the symptom. What is the first line though? Testosterone replacement, if appropriate. With menopause, we see hot flashes, night sweat, vaginal dryness, mood swings. So what labs do we need? Follicle stimulating hormone, estradiol. Why is that? To confirm menopausal status. What is the first line? HRT, if no contraindications. SSRIs for vasomotor symptoms. So we treat what we see. You look for the cause and treat the cause. What about prolactinemia, galactoria, amenorrhea, fertility, visual changes are things that we see. Serum prolactin, MRI, pituitary are the labs that we need to draw for this patient. What about diagnosed pituitary tumor? Why is that? That's why we rule it out, because if we don't diagnose pituitary tumor with this workup, galactoria can also come with other things. It can even come with something as small as our psychotics, can cause galactoria. Amenorrhea can be caused by so many medications. Infertility, anything can cause that. Visual changes, many meds can actually cause that. So we need to rule out that this is truly prolactinoma. So we have to obtain the lab prolactin. We have to do MRI of the pituitary gland. When we confirm it, what do we fix it with? Dopamine agonists like sebagoline. SIADH also is the next one. Hyponatremia, confusion, fatigue is what we see with SIADH. What labs do we need to obtain? Serum sodium, serum osmolality, or urine osmolality, urine sodium. Why is that? We need to diagnose the cause of dilution or hyponatremia, fluid retention, treat underlying cause. Now we're going to quickly go next to the next slide. Diabetes insipidus, polyuria, polydipsia, and dilute urine is what we see with diabetes insipidus. With diabetes insipidus, you're peeing a lot, right? Now, so what labs do we need though? Serum sodium, serum osmolality, urine osmolality, water deprivation. Now, these all have values and ranges to go with them, but we're not getting into that right now. We're just going straight to, okay, what labs do we need? At least build that foundation, then you advance. So why do we need it? Of course, to make sure that we're not mixing up central and nephrogenic together. So we need to see what the cause is and treat the cause. If we do establish that this is in fact diabetes insipidus, what do we need to treat it with? Desmopressin, thiazide. These are things we're going to use, again, depending on the cause of it. If it's a central diabetes insipidus, you use desmopressin. If it's nephrogenic diabetes insipidus, you use thiazides. All right? And that is pretty much it. So now, advanced content here. When we see diabetes insipidus, diabetes mellitus, hypothyroidism, other things also look like it. When we say other things look like it, that is now the differential diagnosis. So with type 2 diabetes mellitus, what else look like it? The closest is type 1 diabetes. Does it make sense? And of course, the mnemonic to remember is too much insulin resistance and stuff like that. What about type 1? The closest is type 2. It is important to know where your differential is. It is important to know what else is close to it. All right? We're going to take a quick question here before we proceed. Any questions? It's right here. So this is an advanced content. When you start talking about differential, you are thinking about, okay, what else is close to this? That way, your confusion is less. So differential diagnosis have its own really relevance, right? Hypothyroidism is close to depression. Hyperthyroidism is close to anxiety. Hashimoto's thyroiditis is close to hypothyroidism, the non-autoimmune one. Graves' disease is close to other hyperthyroid disorders. Hyperparathyroidism is close to malignancy-related hypercalcemia. Hypoparathyroidism is close to vitamin D deficiency. Vitamin D deficiency is close to hypoparathyroidism. It only makes sense. Osteoporosis is close to osteomalacia. Metabolic syndrome is close to diabetes, type 2 diabetes. Obesity is close to Cushing's syndrome. It looks like it by the time your face is round and stuff like that, right? PCOS will look like non-classic CAH. So irregular periods, cysts, and all that. So periods come occasionally and, and go. But they also have issues with childbirth, unfortunately. Now, adrenal insufficiency is close to hypothyroidism. Cushing's syndrome is close to metabolic syndrome. See, obesity is close to Cushing's syndrome. Cushing's syndrome is close to metabolic syndrome. Metabolic syndrome is similar to obesity. It's the same as obesity. Can you see how they all crisscross? Pheochromocytoma is close to panic attack. The way it shows, the way it presents itself. Hyperaldosteronism is close to essential hypertension. Hypogonadism is close to depression or hypothyroidism. Menopause is close to hyperthyroidism or depression. Prolactinoma is close to hypothyroidism or pregnancy. SIADH is close to hypothyroidism and Addison's. Diabetes insipidus is close to psychogenic polydipsia. And that is it for the endocrine system. We're now going to dive right into Q&A. Are we ready for this? Please drop your answers in if you know it. The 24-year-old underweight female presents with fatigue, weight loss, frequent urination. Our fasting blood sugar is 280 milligram per DL. Lab shows C-peptide levels. What is the most likely diagnosis and what lab confirms it? That is double dip right there. A, type 2 diabetes. B, confirmed by, A, type 2 diabetes confirmed by fasting glucose. B, type 1 diabetes confirmed by low C-peptide. C, metabolic syndrome confirmed by insulin resistance. D, type 2 diabetes confirmed by elevated A1C. What do we think, providers? So much for your responses. I got enough response in the chat now, so we're going to keep it moving. Type 1 diabetes confirmed by fasting glucose. Why is that wrong? Let's not approach it this way. Let's approach it this way. Put the two wrong answers that is likely wrong. Put the two wrong answers in the chat. The two wrong answers. This one was not difficult anyway. So I really think we should be able to get through this one really fast. So we know the final answer here for sure is B. Okay, but if you have to pick two wrong answers, A is out and D is out. Those are two obviously wrong ones. Okay. Type 2 diabetes confirmed by fasting blood sugar. Type 2 diabetes, you want to remove those two. They parallel together anyways. There's an opportunity to just knock those two out. Then you have to worry about, okay, it's probably C or B or C. And now you can just definitely see, okay, weight loss, fatigue, and they said blood sugar, and they said underweight female, present with fatigue and urination. And then C peptide levels is your major clue right there. C peptide levels. And that will connect you with type 1 diabetes. B, final answer. Okay, now let's look at the rationale. Look at it. Type 1 diabetes is an autoimmune condition with destruction of pancreatic beta cells, resulting in little to no insulin production. C-peptide is a byproduct of insulin production. A low level confirms insulin deficiency, pointing to type 1 diabetes. So your major clue is the C-peptide. Type 1, rule out with C-peptide. Type 1, you want to rule out with C-peptide. So the patient is young, underweight as a classic symptom of type 1 diabetes, making is the best fit. Now type 2, confirmed by fasting glucose, is incorrect because fasting glucose is more than 126 support diagnosis of diabetes, it does not distinguish between type 1 and type 2. So type 2 usually is seen in overweight, of course, insulin resistant adults. The patient is underweight. That is a major rule out. That's why we rule out A and D. Okay. And of course, metabolic syndrome is confirmed by insulin. Confirmed by insulin resistance is wrong because it includes central obesity, high triglycerides, low HDL, hypertension, elevated fasting glucose. Patient does not show these features. No insulin resistance tested or mentioned in the case. Now, don't be reading into the question. Focus on what exactly they're asking you. You want to say, okay, what exactly are they asking me? Type 2 diabetes is confirmed by hemoglobin A1C. Hemoglobin A is incorrect because hemoglobin A1 is supposed to confirm the presence of diabetes, but cannot distinguish what the type of diabetes that you got. This patient's clinical feature is more consistent with type 1 diabetes. Thank you so much for your participation. Speaking is Dr. Kehinde Elisha, founder and CEO of MP Certification Academy. The next thing we're now going to go to is question number 2, case number 2. A 45-year-old woman presents with fatigue, cold intolerance, weight gain. She has been taking SSRIs for depression with minimal improvement. Question: what tests or which test should be ordered to rule out metabolic cause? A, cortisol, B, LH or FSH, C, TSH and free T4, D, hemoglobin A1C. What do we think? Please drop your answers in. This is pretty straightforward, right? What is your diagnosis? Diagnose first. If you diagnose first, based on this, you and I will agree that this is what? Hypothyroidism. So if it is hypothyroidism, what do we see? We see increased TSH level, right? So TSH is one of the things we're going to work on. That will be our clue. C, final answer. Okay, so content is still key here. The ability to diagnose is a big deal on this test. You have to know your diagnosis. So let's take a look at the rationale. Hypothyroidism commonly mimics depression. TSH, thyroid stimulating hormone, and free T4 are the best initial tests to evaluate thyroid function. Elevated TSH with low free T4 confirms primary hypothyroidism. Now, with cortisol, it's incorrect mainly because it is a test that we use for adrenal function like Addison's disease or Cushing's disease. Not the very first line for evaluating fatigue or depression-like symptoms. LH or FSH is incorrect because it evaluates gonadal or menopausal status. This does not explain cold intolerance and weight gain. Hemoglobin A1C is used to diagnose or monitor diabetes, not fatigue or cold intolerance. So C, final answer. Let's look at the third case. So a 34-year-old female. A 34-year-old female is a keyword. Present with palpitations, heat intolerance this time, weight loss this time, and exophthalmos. Which lab and physical finding confirmed the endocrine diagnosis? A. TSI antibody and exophthalmos. B. TSH and mood swings. C. Hemoglobin A1C and palpitations. D. Free T3 and tachycardia. Drop your answers in the chat, please. Okay. I'm just spelling that out, but it is in fact the final answer. It is thyroid antibody, thyroid stimulating hormone antibody, and exophthalmos. But what are we thinking when we saw this question, though? Is it hypothyroidism or is it hyperthyroidism? Let's diagnose this first. Don't forget, this is Graves' disease, hyperthyroidism. And that kind of led us to a final answer. So, thyroid stimulating immunoglobulin confirms autoimmune hyperthyroidism, aka Graves' disease. Exophthalmos, that's the bulging of the eye. I remember that eye in the biology book. Is pathognomic for Graves' disease, not seen in simple anxiety. TSH and mood swing. TSH may be low in hypothyroidism, but mood swings are non-specific and could occur in anxiety or other conditions. It doesn't clinch the diagnosis. Hemoglobin A1C and palpitations is incorrect because hemoglobin A1C assesses glucose, not thyroid. Palpitations are non-specific and seen in both anxiety and hyperthyroidism. Free T3 and tachycardia is incorrect because while free T3 is elevated in hyperthyroidism, tachycardia is also seen in anxiety. Without a more specific sign like exophthalmos or TSI, this is not enough to confirm the diagnosis. Okay, let's take a look at another question. Here's a 38-year-old woman. 38-year-old woman, keyword. Present with weight gain. Weight gain, keyword. Of course, easy bruising is a bruising keyword. Purple abdominal striate, keyword. And then she also reports new onset of hypertension. Which of the following is the most appropriate initial lab to confirm the suspected diagnosis? A. Hemoglobin A1C. B. TSH and free T4. C. Dexamethasone suppression test. D. Serum creatinine. What do we think? Abdominal striae, weight gain, is a bruising, round face. What are you suspecting? What is Cushing's disease? Okay, now that we have that in order, what is now it's easy for us to pick an answer. Dexamethasone suppression test. C, final answer. We know it's not hemoglobin A1C, it's not TSH. We saw the relevance of this just now. We know it's not serum creatinine, that's about the kidney. So dexamethasone suppression test confirms cortisol overproduction seen in Cushing's. First line for diagnosing hypercortisolism. Now, you only know that this is hypercortisolism. Wait a minute, that's a cortisol. Yeah, which is of course Cushing's. Too much cortisol will lead to Cushing's. Okay, hypercortisolism will lead to Cushing's. Okay, so C is the final answer. Hemoglobin A1C is wrong because it may be elevated in Cushing's, but it's not diagnostic. It does not confirm cortisol excess. TSH and free T4 evaluate thyroid function unrelated to moon phase or striae. Serum creatinine may assess kidney function, but it's not relevant to diagnosing Cushing's. Let's look at case number 5. It's a 62-year-old woman presents with bone pain, fatigue, and kidney stones. Lab reveals elevated calcium and elevated parathyroid hormone. What is the most likely cause of hypercalcemia? A. Multiple myeloma. B. Primary hyperparathyroidism. C. Vitamin D toxicity. D. Hyperparathyroidism. There is primary hyperparathyroidism and there is hyperparathyroidism. So don't mix those two up. What will you likely eliminate first? What is the main thing you want to eliminate first? This is not telling us anything about multiple myeloma. And C is out. I'm going to suspect B and D, right? Thank you so much for your responses. And I'm seeing a lot of people actually getting the answer right. The final answer that makes sense is going to be B, primary hyperparathyroidism. Okay. And primary hyperparathyroidism is characterized by what? Elevated calcium and PTH, sorry about that. And that's a classic sign. What is incorrect? Multiple myeloma can cause hypercalcemia but would show low PTH due to suppression. Vitamin D toxicity causes high calcium but typically low PTH. Hypoparathyroidism causes low calcium, not elevated calcium level. Okay, so we got more questions. That is pretty much the last one that was left actually. And then you can do that on your own. You have access to it. We're now going to go to clinical assessment tools. Okay, history and physical exam. Identify symptoms like fatigue, weight changes, hair loss. What about growth charts? For pediatrics, you want to evaluate shorts. Are they shorts? Do they have early puberty? Do they have pituitary, thyroid, and gland issues? BMI calculation, you want to assess, do they have obesity? Any metabolic syndrome? What is the waist circumference? Can you detect any kind of central obesity, a marker for metabolic syndrome? What about blood pressure monitoring? Hypertension may suggest Cushing's pheochromocytoma or hyperaldosteronism. What about visual field testing? Screens for bitemporal emanopsia in pituitary tumors. What about skin inspection? Looks for hyperpigmentation, vitiligo, striae, dry skin, hirsutism. Addison's, Cushing's, PCOS, and hypothyroidism. You want to inspect skin for all of that. What about the labs? This is now repeating. You will now see that things are repeating, right? So for thyroid disorders, TSH, free T4, free T3 are the common labs that we order. For diabetes diagnosis and monitoring, hemoglobin A1C, fasting glucose, or GTT is what we order. Now, differentiation between type 1 and type 2 is mainly C-peptide. With C-peptide is associated with type 1 diabetes. What about autoimmune disorder? It's low in type 1 diabetes. It can be normal or high in type 2, so it's not specific for type 2, okay? Now, with autoimmune thyroid disease, Hashimoto's the anti-TPO and TSI antibodies is used for Graves' disease. What about the PTH, calcium phosphate? We use that for parathyroid disorders. ACTH, cortisol, we use that for adrenal insufficiency and Cushing's syndrome. Renal and aldosterone levels, which we use it for hyperaldosteronism. Prolactin, pituitary adenomas. Testosterone, LH, FSH, we use for hypogonadism, PCOS, and menopause. Vitamin D, we use for bone health, secondary hyperparathyroidism. Urine catecholamines, plasma, metanephrines, we use for pheochromocytoma. What about imaging? Neck ultrasound, we may be trying to look for like thyroid nodules or goiter. For DEXA scan, it assesses bone mineral density. MRI of the pituitary will evaluate adenomas or masses like prolactinoma. CT MRI or adrenal glands assess adrenal tumors, Cushing's or pheochromocytoma. Pelvic ultrasound detect ovarian cysts. X-rays will, detect bone age assessment for growth delays. And that is it. So now we have some cases to follow similar to the case. This one is just about tests and procedures. So ensure that you take a look at those questions and make sure you just, check them out, play through them, try to understand how the examining body is going to ask you questions on tests and procedures. Then we have the pharmacology of the endocrine system. We spoke about a few of them before, but we're going to talk about a little bit more now and in a little bit more depth. We're going to be talking about the mechanism and the clinical rationale for actually choosing this drug. So why do we give levothyroxine for hypothyroidism? First of all, what is the mechanism of action? It's a synthetic T4 converts to active T3 in the body. It mimics a natural hormone is the main reason why we choose it. It is well tolerated and it's it's a predictable dosing. Methimazole is used for hyperthyroidism. It inhibits thyroid peroxidase, blocks T3 or T4 synthesis. But why do we choose it though? Because it has fewer liver side effects versus the PTU. PTU is also an option, but methimazole has fewer side effects. Because they will also ask you on exam why you're choosing what you're choosing. They want to test your knowledge that you actually know what you know, that you're just not doing guesswork. Now, PTU is used for hyperthyroidism in pregnant folks during the first trimester. What is the mechanism of action? It inhibits thyroid hormone synthesis and of course T4 to T3 conversion. Why do we choose it? Chosen early in pregnancy, it is less teratogenic than methimazole. Methimazole is not ideal for somebody that is pregnant. That is why we choose PTU for pregnant moms. Now, PTU is not really efficacious like methimazole, but we can use methimazole in general population for hyperthyroidism. Now let's talk about insulin. Type 1 and type 2 diabetes is what we use insulin for. It can be, ideally it's for type 1, right? Now, when we have resistant type 2 treatments to metformin, for example, we're going to shift gears to, type 1. So what is the mechanism of action? It replaces endogenous insulin. It lowers glucose. Why are we choosing insulin? Required in type 1 for sure. That's the only thing that we can do. Or that's the main thing that we can do. And it's also used in oral agents and when oral agents fail or during acute illness. Metformin biguanide is used for type 2 diabetes. It can decrease hepatic glucose production, increase insulin sensitivity. What is the first line for type 2 diabetes? No weight. It is the first line. It's good for first line. Metformin is good for first line for type 2 diabetes mellitus. And of course, you don't gain weight while on it. And of course, you don't drop your blood sugar too fast. Just like with insulin, you can drop your blood sugar way too fast. What about GLP-1 agonists like semaglutide, liraglutide? These used for type 2 diabetes and obesity as well. What is the mechanism of action? It actually mimic incretin. It increases insulin, it decreases glucagon, and it decreases your appetite. So you don't eat as much. So we think food is a source of weight gain all the time. I kind of disagree with that. Some weight gain is just sedentary, like you just don't move enough. And most of us are just like that in healthcare. So food is maybe a part of it too, because you can cut down and tone down what you eat at least, right? To make up for the times that you don't move, but it still wouldn't match. But if you realize by the time you start moving, it kind of works hand in hand with the diet. So why are we choosing GLP-1 agonists like semaglutide and liraglutide? It promotes weight loss, low hypoglycemia, and cardiovascular benefit. What about SGLT2 inhibitors like empagliflozin? It's used for type 2 diabetes, heart failure. It can block glucose reabsorption in the kidneys. It will increase urine glucose excretion. So why are we choosing it? Because it will improve blood glucose, it will help with weight, and it also reduces cardiovascular risk and renal risk. Sulfonylureas, like glipizide, is used for type 2 diabetes. What is the mechanism of action? It stimulates insulin release from pancreas. It is cheap but risk of hypoglycemia and weight gain. What about thiazolidinone? Like we call it TZDs. Easy to pronounce. You don't have to pluck your teeth over that. This is for type 2 diabetes. And of course, it is increased insulin sensitivity in muscle and fat. Extremely good for insulin resistance, but risk fluid retention though and fractures. That is the downside of TZDs. What about calcium and vitamin D? We use for osteoporosis, hypoparathyroidism. I always emphasize my thyroid whether it's hyper or hypo, because we can't mix those two things up. What is the mechanism of action of calcium and vitamin D? Is supplement for bone mineralization and PTH support. So why are we choosing it? Prevent and treat bone loss and support calcium homeostasis. What about bisphosphonates like alendronate? It's used for osteoporosis. What is the mechanism of action? It inhibits osteoclasts, bone resorption, right? Now, why are we choosing it? It is a very first line for bone loss prevention, especially postmenopausal women. What about cinacalcet? Hyperparathyroidism, especially secondary. And of course, the mechanism of action is that it increases calcium sensitivity of parathyroid and it decreases PTH in return. So it is used in CKD or non-surgical candidates. That's why we choose it. What about hydrocortisone or prednisone? Whenever we have adrenal insufficiency, this treatment is very ideal. Adrenal insufficiency, aka Addison's disease. Now, for every pathology, make sure you also know the second name. It replaces cortisol or anti-inflammatory and metabolic effect. Why are we choosing it though? Why do we choose hydrocortisone or prednisone? Because it's needed to prevent what? Adrenal crisis. We don't want to throw patients into that. That is not a good thing. It mimics circadian rhythm as well. That's why we choose it. Fludrocortisone. That one is used for Addison's disease as well. It's a mineralocorticoid replacement. And of course, it acts like aldosterone, sodium retention, potassium excretion, that cascade. They help maintain blood pressure and fluid balance, right, in the adrenal, in a patient with adrenal insufficiency. Now, what about cabagrelin, prolactinoma? It's a dopamine agonist. Don't forget, you cannot say agonist when you mean to say antagonist. You cannot say antagonist when you mean to say agonist. Agonists, we're giving it to them. Antagonists, we're blocking it. So these dopamine agonists, they are getting it, right? Inhibit prolactin secretion. They work in opposite ways, okay? Now, what about why choose it? It shrinks tumors, restores fertility, and oral dosing. What about desmopressin? Central diabetes insipidus, synthetic ADH increases renal water resorption, and then prevent polyuria and dehydration in ADH deficiency. What about spironolactone? Hyperaldosteronism, PCOS. Okay, what is the mechanism of spironolactone? Aldosterone antagonist, see? Aldosterone antagonist, and therefore a potassium-sparing diuretic. Does it make sense now? Aldosterone antagonist, so it's a potassium-sparing diuretic. So why are we choosing it? Because it's going to help manage hypertension, it's going to decrease androgens in PCOS, and it's going to protect K+, which is going to be pretty much, it's not really protect K+. That would be a wrong use of word, really. Okay. The right use of words would be, it's going to spare potassium. It's going to keep potassium from going out of the body. So we're not going to be losing potassium. But at the same time, potassium can then build up and create problems too. So we just have to maintain a balance. So key decision-making factors for NPs, patient-specific factors, pregnancy, age, renal function test, cause, comorbidities. These are how we're going to pick medication. How do you select medication? Just don't pick just to pick. As well on your exam, look at the big picture before you pick a medication. Side effect profile, risk of hypoglycemia, sulfonylureas, weight gain, or fluid retention. Evidence-based guidelines, ADA, AACE, ATA, CANMAT, and others guide our first line choices. Insurance coverage, access to care, and all that would determine what to pick. Let's take a look at this question. A 55-year-old man with newly diagnosed type 2 diabetes has hemoglobin A1C of 7.81%. He is overweight and has no contraindications. What is the best initial medication? A, insulin, B, metformin, C, sulfonylurea, D, GLP-1 receptor agonists. Drop your answer in the chat, providers. Saying multiple answers in the chat. I'm saying just one answer in the chat. We've said it many, many times. Type 2 diabetes, oral is always the best. This person has no contraindication to this drug. We We don't have to worry about lactic acidosis or anything. The final answer is going to be metformin. Metformin is the very first line due to efficacy, weight neutrality, cardiovascular benefits, and low hypoglycemia risk. Insulin is reserved for severe hyperglycemia or failure of oral agents. So our first line for type 2 is definitely oral. Our first line for type 1 is definitely insulin. See? Now, when we have resistant type 2 treatment, then we go to insulin. But we don't jump right on insulin first. Sulfonylurea like glipizide, if it's effective but higher risk of hypoglycemia and weight gain, generally second line after metformin. GLP-1 receptor agonists, often used after metformin or in patients needing weight loss or cardiovascular risk reduction, not the initial therapy. Let's take a look at question number 2. All right, question number 2 is a pregnant woman in her first trimester is diagnosed with Graves' disease. Which anti-thyroid medication is preferred? A. Methimazole, B. PTU, C. Radioactive iodine, D. Beta blocker. Approach this question this way. Keyword: pregnant woman, a first trimester, diagnosed with Graves' disease. Now, pick out the population because it's important. What we pick for this woman is going to be important. We just went over it in content. I'm expecting 100% answer. Providers, guys, 100%. Now, remember, we're talking about PTU not being the best efficacy-wise, but because this woman is pregnant, we're shifting to that. Now, if you don't have pregnant woman in your question, tell me, how will you treat this patient? Let me say you don't have a pregnant woman there. What will you pick? What is your priority pick without a pregnant woman? And you're going to pick methimazole if there is no pregnant woman story there, because methimazole is actually more efficacious, but we skip it and jump right on PTU because this woman is pregnant. Methimazole have a high what? Teratogenicity. We're now going to flip to rational and see what it is. PTU is preferred 100% everybody due to lower teratogenic risk. Switch to methimazole later when the baby already formed, right? Now, methimazole risk of teratogenicity in the first trimester, you want to avoid initially. Radioactive iodine is contraindicated in pregnancy due to fetal thyroid damage. Beta blockers alone, symptomatic control only, does not treat the underlying disease. Question number 3 is a 62-year-old postmenopausal woman has osteoporosis diagnosed with DEXA scan. Which medication is the very first line to reduce the fracture risk? Calcium supplements alone, bisphosphonate, aka alendronate, not aka, example, alendronate that belong to that class, estrogen therapy, decalcitonin. What do we think? Participation, absolutely. We know the final answer is bisphosphonate. It is the very first line therapy. It inhibits bone resorption and, of course, reduces fracture risk. Calcium supplements alone will not help. It's important, but it's not enough. Okay, so we're now going to shift gears and go to question number 4. A patient diagnosed with Addison's disease requires hormone replacement. Which drug replaces glucocorticoid deficiency? Will you remember this? A. Flucortisone, B. Hydrocortisone, C. Prednisone, D. Dexamethasone. Do you now see the reason behind the foundation that we did? Drop your answers in the chat. And when we look at Addison's disease, absolutely. Thank you so much for your responses. The final answer is glucocorticoid replacement that mimics the natural cortisol. Fludrocortisone is a mineral corticoid replacement, does not replace cortisol. Prednisone is used, but hydrocortisone is preferred because it has a shorter half-life and physiological effect. Dexamethasone is a potent glucocorticoid, and of course, it lacks mineralocorticoid activity and longer half-life. It is less physiologic. Okay, so we have a few more questions here that you can do. Okay, make sure you finish the rest. But let's now look at the test-taking strategy. So what is the strategy to approach this particular body system or most of the body systems? You want to read this term very, very carefully. Identify the key symptoms first, labs, and patient contents. I will add to this one and diagnose. When you identify symptom, whenever it's possible for you to diagnose, and then take that diagnosis to your answer. That's what I'm saying. So you have to be able to diagnose. It's not a choice. Endocrine disorders often have overlapping symptoms. Details matter. The age also matters. It's going to also help you differentiate things. Identify the main clinical problem. Is it hypo or is it hyper? Is it related to a specific gland? Connecting these dots is also a test-taking strategy. Narrow down the possible endocrine disorders early. Note any lab value provided. Look for patterns. Is it elevated TSH? Is it low free T4? Is it hypothyroidism? Is it high calcium? Is it hyperparathyroidism? Labs often clinch the diagnosis, understand normal ranges and hormone feedback loops. You want to use mnemonic if you have it, if you want to use it. For me, it's not. It's an additional study for me, but if you like mnemonics, please go for it. Bones, tones, groans, and moans for hyperparathyroidism. It just kind of help you remember the symptoms that you see with hyperparathyroidism. It's going to help you recall the associated signs and symptoms. Consider patient-specific factors. Are they pregnant? What is their age? What is their comorbid condition? Any contraindication? Some drugs like PTU versus what? Methimazole in pregnancy or diagnosis of type 1 versus type 2 would depend on patient factors. What about prioritize first-line treatment? Absolutely. No guideline preferred medications. Like metformin is the first line for type 2 diabetes. Levothyroxine is the first for hypothyroidism. So many questions will focus on standard of care management and clinical guidelines too. Now you got to watch for distractors though. You want to eliminate options that are outdated, overly broad, or unrelated to endocrine physiology. Many options may seem plausible. You want to narrow down by relevance. What about analyze drug mechanism when pharmacology is tested, match drug actions with pathophysiology like GLP-1 agonists, increase insulin secretion, and promote weight loss. You want to understand mechanism help rule out wrong choices. Want to manage time effectively. Don't spend too much time on a single question. You want to flag and return if needed. You want to ensure to get all questions in the exam. You want to make sure you get to it. You want to touch up on everything. Know your lab and interpretation. Differentiate similar presentations. Recall. Remember, I was telling you that when you have similar presentation, it's going to throw you off on the exam. For example, hypothyroidism versus depression. You must be able to separate that too. Recall side effects of endocrine drugs. Help answers questions, about contraindications and patient education. You want to practice clinical scenarios, real world applications, improve. It's going to help you improve retention. It's like you're soaking yourself in. It's like you're getting that clinical in that you never really got as a student. What about the other endocrine concept? Hypothalamus to pituitary to target glands. Central control of hormones, via releasing or inhibiting hormones. Increased TSH, decreased free T4, leads to hypothyroidism, usually Hashimoto's autoimmune. Decreased TSH, increased free T4, may be hyperthyroidism. That's Graves' disease is common cause of that. Type 1 diabetes mellitus, autoimmune destruction to absolute insulin deficiency leads to required, insulin replacement. What about type 2 diabetes is insulin resistance plus relative insulin deficiency will lead to you managing it with lifestyle and metformin. So type 1 diabetes is an autoimmune destruction. Type 2 diabetes is insulin resistance due to weight gain and lifestyle changes. Now, Cushing's syndrome is excess cortisol, will lead to central obesity, striae, hypertension, glucose intolerance. You've heard this a lot now, right? It's looking like a repetition now. That is what it should feel like. That is what studying is all about. It's about soaking you all in it. Listen, there are no strategies without content. Absolutely none. Stop looking for questions. Start focusing on content. When you have your content, you can answer so many things. Dr. Kehinde Elisha speaking here, founder and CEO of MP Certification Academy. To reach us, nurse-to-nursecoach@gmail.com or www.npcertificationacademy.com. You can also visit us, confidentprescriber.com, if you pass your boards already and you want to, just sit in after you pass and you want to sit in and get more knowledge. So let's continue here with Addison's disease. Adrenal insufficiency, fatigue, hyperpigmentation, hypotension, hyponatremia. What about primary hyperparathyroidism? Increased PTH, hypercalcemia, kidney stones, bone pain, SIADH, excess ADH, hyponatremia, and euvolemia plus concentrated urine. With diabetes insipidus, ADH deficiency, polyuria, dilute urine, hypernatremia. Levothyroxine, synthetic C4 for hypothyroidism, monitor TSH for dose adjustment. Methimazole will block thyroid hormone synthesis. You want to avoid them in the first trimester. Metformin would decrease hepatic glucose production. It is the very first line for type 2 diabetes. With insulin, we need it for type 1 diabetes. In cases of type 2 diabetes, when we have resistance to metformin, we're going to go to insulin as well. GLP-1 agonists will increase insulin secretion. It's going to promote weight loss, and cardioprotective is also a good part of GLP-1. Now, SGLT2 inhibitors, that will promote glucose excretion via kidneys, so it is very, very good for heart failure patients. Bisphosphonates will inhibit osteoclasts to treat osteoporosis, risk of jaw osteonecrosis. You got to pay attention to the risk here, because when you're giving this med, you need to also educate the patient, let them know what they are getting into. It's only fair, it's only ethical. Hydrocortisone replacement for adrenal insufficiency. It mimics circadian rhythm. Sabaglogolin, dopamine agonist to treat prolactinomas, shrinks tumors, reduces prolactin levels. That ends our endocrine system. Speaking is Dr. Kehinde Elisha. You can visit our website for our multiple resources, and a lot is to come, and we look forward to having you in our community of students and community of experts. Do we have any questions at this time? I really hope I didn't bore you. We actually finished earlier than I thought. So what I'm thinking about doing right now, we skip the questions on lab, right? Can we take some questions on lab now that we have time to actually do it? What do you think? A 37-year-old woman, keyword, present with fatigue keyword. Weight gain, cold intolerance, of course, you know what this is already. Well, you suspect hypothyroidism, that's a cheap question right there. They will never tell you that. But at least we know it's hypothyroidism already anyway, even before the question said it. Which of the following is the most appropriate initial test? A, T3, B, anti-TPO antibodies, C, TSH, D, reverse 3. What do we think? Please drop your answer in the chat. The final answer is going to be TSH. We're talking about, whenever we talk about hypothyroidism, your TSH is always one of the first line tests to do. So for assessing thyroid function, if elevated, you want to confirm with free T4. So free T3 it fluctuates a lot, and it's not the best test, and it's more helpful with hyperthyroidism instead. Anti-TPO antibodies is useful for confirming autoimmune like Hashimoto's, but it's not for initial screening. Reverse 3, that one is rarely used in routine primary care, but of course sometimes it's used for critical illness to assess T3 clearance. Let's now take the last question here. It's a 53-year-old man with central obesity, hypertension, and elevated triglycerides. You are evaluating him for metabolic syndrome and diabetes. So which lab provides an overview of an average of glucose levels over the past 3 months? This should be a piece of cake for every provider in the house. Is it random glucose? Is it, hemoglobin A1C? Is it oral glucose tolerance test? Is it fasting insulin? We know the final answer is hemoglobin A1C. B is the final answer. Okay. Hemoglobin A1C reflects 2 to 3 months average of glucose levels, and it's the key test for diagnosis and monitoring. What is incorrect? Random blood sugar level, useful for in acute settings, but doesn't reflect chronic control. Oral glucose tolerance test, that one is more cumbersome, really. It's used for, I remember doing this when I was pregnant. They have to check your health when it comes to whether you have diabetes or not. Typically used for, when A1C or fasting glucose is borderline. Now, fasting insulin may suggest insulin resistance, but not diagnostic for diabetes. B is the final answer. So please get the rest of the lab questions done. It's in your slide in Canvas. Don't forget, stay in Canvas. Don't go from review to review. Too many resources will not be a good thing. Don't forget also, if you're testing this week or anytime, make sure you don't change your answers at the last minute. If you change more than 3 questions, you're doing too much, okay? You got to slow down and walk away from that screen. But if you're changing because you're really sure or because you missed something, then that's okay. When you flag a question, it doesn't hurt if you don't go back to unflag it. You can flag your question if it's too thick, but make sure you spend no more than 1 minute on every question. We are here to support you, and we're going to continue to support you. Thank you so much for trusting on us, and we don't take this lightly at NP Certification Academy. We're now going to move to the next body system. Do we have any questions? Thank you.